Good luck, everyone.
Thank you.
Thanks. I have a wicked headache.
I have it now from this.
I think I have a fever.
I have sympathetic Ebola.
I just want to go with you when you're prepared for me.
I know.
All right.
Drove you off the road, actually.
The whole world is exploding. My nephew's ship is in quarantine. So, tell me when. It's good to hear.
You good?
Coolest better. Tell me when to go. No, please, I can't go that Belgium. Like a 4-year Belgium. 7-year plan with the shit, I think. Oh, I'm on a 4-year. Already have 60 people on the call. How many? 100.
Joanne, you can begin.
Thank you. Good evening, everyone who is on the call. My name is Donna Kelly Williams. I'm the president of the Massachusetts Nurses Association, National Nurses United, and it is my pleasure to welcome you to this telephone town meeting. Before we get started, I'd like to take a moment to address the public health crisis affecting us with the recent events of the Ebola virus contracted by 2 registered nurses in Texas. Clearly, nurses have identified we have not received appropriate training and equipment. Hang on. We're just, to everyone on the line, just hang on, and I'll start again.
It might give them a minute because there's a lot of people joining. So
there's a lot more people that are coming on to the call right now, so and I will hold off for just a minute until they are all set, and then I will start again.
repeating it that for those of you that were holding while others join the call.
For those of you that are on the call right now, if you could just hold on for a few more moments. We're just waiting for other people to get on the call.
That's on.
Your phone is on.
It's all us calling.
Yeah, mine is too.
If you're in the room and you have your cell phone, it's going to ring for your call.
Conference call is now calling you.
All right, that's what that call was.
So everyone that's on the phone, if you can just hang on, we're just completing the reach out to all of the telephone numbers that we have on record.
This is pretty impressive, actually.
Just a few more minutes if you can hang on. We'll be ready to begin in just a few minutes.
Once we hit 1,000, you want to start?
So what's the time frame?
Just keep rolling. This phone, we basically want to see that they're getting in touch with 23,000 members. And
Go ahead.
Okay, so we're going to get started. Good evening, everyone who is on the call. My name is Donna Kelly Williams, president of the Massachusetts Nurses Association, National Nurses United, and it is my pleasure to welcome you tonight to the telephone town meeting. Before we get started, I'd like to take a moment to address the public health crisis affecting us with the recent events of the Ebola virus that was contracted by 2 registered nurses in Texas. Clearly, nurses have identified we have not received appropriate training and equipment. Tomorrow, there will be a public hearing at 10 a.m. at the State House. M&A has asked to testify but have been turned down. We will be there ready to testify and to talk to the press. I encourage anyone able to attend. We will keep you updated on this. The purpose of tonight's meeting is to discuss the new landmark law now in effect that requires all acute care hospitals in Massachusetts to adhere to safe patient limits for registered nurses working in all types of intensive care units. This is your opportunity to ask questions about the law and to share your experiences about how the law is being implemented or not implemented in your own facility. We are also using this call to gather information to help us in preparing for an important meeting coming up on October 29th, where the Health Policy Commission, the governmental body charged with overseeing the implementation of this law, will be developing an acuity tool that will be used to determine if and when an ICU nurse can take a second patient. If you have questions about other matters, please feel free to call your M&A Associate Director, or you can call me at the M&A office in Canton. I am joined tonight by M&A and NU Executive Director Julie Pinkham, Karen Higgins, Co-President of National Nurses United, and several board members and several other members. Also joining me on the line are members of the M&A staff. If you want to ask questions at any point in tonight's discussion, just push 0 on your phone. We will take questions in the order that they are asked. When it is your turn to ask your question, we will ask that you provide your name and if you belong to an M&A bargaining unit, what bargaining unit you work at, as well as the type of unit that you work on. Before we open up for questions, we wanted to provide a brief overview of the new law. As I stated earlier, the new law is now in effect and should be followed in all Massachusetts hospitals. It requires hospitals to adhere to safe patient limits for registered nurses who work in all the state's hospital intensive care units, ensuring that no nurse can be assigned to more than one patient or in certain circumstances no more than 2 patients based on the assessment of the staff nurses on that unit, not managers or supervisors. You can view a detailed primer on the new law by visiting our website at www.massnurses.org and clicking on the ICU Law button on the right-hand side of the page. There you can find the full text of the law. Some highlights of the law include: the new law applies to all acute care hospitals in both state and public hospitals and all manner of ICUs as defined by the Department of Public Health, including NICUs, PICUs, CCUs, SICUs, MICUs, and etc. The law sets a limit of 1 patient per nurse. A nurse can only take a second patient based on the assessment of the staff nurses in the unit and a soon-to-be-developed acuity tool. The acuity tool will have standardized criteria to determine the stability of the patient, and all hospitals will be using the same criteria. Further, in no instance and under no circumstances can an ICU nurse be assigned a third patient. A powerful aspect of the law is the fact that it is the staff nurses on the unit who assess the acuity and stability of the patient, and it is the staff nurses on the unit who determine if and when a second patient can be assigned to a nurse. A nurse manager has a say on whether or not a second patient is assigned only in those cases where the staff nurses or acuity tool is in disagreement. The state's Health Policy Commission will regulate the implementation of the proposed law, including formulation of the acuity tool, the method of public reporting of staffing compliance in hospital ICUs, and the identification of 3 to 5 patient safety quality indicators. ICU nurses will have a chance to influence the development of the acuity tool criteria at a public forum to be held on October 29th. The Health Policy Commission is a group we have worked with in the past to establish strong language on what constitutes an emergency situation under our recently passed mandatory overtime law. The HPC will be charged with holding meetings and hearings with stakeholders, including the M&A, and to develop the acuity tool criteria that will objectively measure when the patient is stable enough to allow the assignment of a second patient to a nurse's assignment. Once the acuity tool criteria is established, each hospital will then need to work with staff nurses to incorporate those criteria into their own hospital-specific acuity tool, and that tool must be certified by the Department of Public Health. In M&A and in new bargaining units, the creation of the hospital-specific acuity tool is a subject that must be negotiated with our union nurses. With that overview, we would now like to begin answering any questions you may have. Again, press 0 on your phone if you wish to submit a question. And our first question is from Ellen. Ellen, do you have a question for us?
Oh, it's actually Eileen.
Oh, hi, Eileen. Sorry about that.
No problem. It's Eileen from Boston Medical Center. And I was curious as to, I guess I'm still, even though I've read the newsletters that come out, but I'm very disappointed that the M&A has changed their position from all staff nurses to now only ICU nurses who already have limited staffing ratios when it's 4 nurses who really needed the ratio numbers to begin with. And I'd like to know, I still don't understand. I understand there's some political thing with some other, I don't understand.
So, Eileen, I'll certainly start to answer that question. M&A has not changed their position. M&A still is dedicated to getting safe patient limits in all units across the state. This was the first step in having that happen. We are not done, and it's our goal, and we intend to have safe limits in all units across the state. Thank you. Do we have
So the signature thing that we did was to get, it was for all nurses, not for just ICU nurses.
That's correct. When we were doing the ballot initiative and we were collecting signatures, we had more than just ICU on the ballot for limiting the number of patients assigned to a registered nurse. But as what was explained in the flyer, that is one part of the process of getting a law enacted. Our hope was that we could negotiate into law the law that would protect all patients in the Commonwealth in all units. However, that was the best chance that we could do to get a law in place that we could build on to get it in all units across the state. Thank you, Eileen. Next question is from Lynn. It has to do with boarding. Oh, Lynn, do you want to ask your question?
Yes. Hi, I'm from Good Samaritan in Brockton. I was wondering, I work in an emergency room, and presently hold ICU patients because the ICU is not ready to take them. I envision that we will be holding more ICU patients at this point. So how does this law affect ICU patients in the emergency room?
It won't change anything as far as that's concerned. The law is specific to patients in the intensive care unit. Thank you. Next question is from Rebecca. Rebecca, did you have a question? Rebecca?
I'm Rebecca, and yes.
Hi.
I'm Rebecca. I work at Brigham Women's Hospital, and I work on a cardiac step-down unit. And what I've seen since this law has been implemented is that patients are being dumped out at day 1 to our step-down unit that may not be ready, and we are then playing ICU nurse with this patient in a 4-to-1 situation, making for a very stressful situation. And I had 2 patients that I had just on Friday that had surgery. One was dumped out and the other one did not come until day 2. The one that they dumped out was respiratory compromised, urine output was compromised, vital signs needed to be done more frequently, his blood sugars were out of control, and when I looked at the other patient that they kept there for post-op day 2, till post-op day 2, he had none of these issues. But my patient was a little bit more of an anxiety, driven patient and not as pleasant to be dealt with. And so he came out and this other one stayed in.
So, Rebecca, I'd like to just talk a minute about the acuity tool that's being developed that would identify those patients that need to be in the intensive care unit itself, not be dumped out on the floors. And that's what we will be looking at the development of and would like your input at the meeting on October 29th. It's critical that we hear from nurses about instances just like that that are happening all over the state, and that the Health Policy Commission hear that as well, because they need to hear that exactly what we had anticipated may happen is happening, and they need to hear it directly from the nurses that it's happening from. Thank you, Rebecca. Heidi, you're on the line. Do you have a question?
Thanks, being slow, sorry.
I'm guessing it's more than a statement or a question.
Okay.
I work in an emergency department, and currently it's very difficult to get our patients up to the floor when they will take two, which creates a burden on the emergency room, seeing how that we have 4 to 5 patients currently. And keeping that intensive care patient in the emergency room then causes one nurse to have care of one patient, and then another nurse will have to take on the burden of your other 4 patients.
Mm-hmm.
So this law is actually creating more of a burden on the emergency room, which is already currently overstressed. So I don't think it was well thought out of the rest of the hospital, as that woman that was just speaking from a step-down unit who's being now burdened with patients that are being removed from the unit maybe before they're ready.
Heidi, I think that's what I just spoke about, the Health Policy Commission hearing that we're going to be coming to on the October 29th. All of this information is critical for them to understand what the impact of limiting the safe patient limits to one area, what that impact is going to be on the other units. So I hope that you'll be able to come on the 29th. It's critical that all areas that are going to be impacted going forward have an opportunity to speak at the hearing for Health Policy Commission. Anybody else want to comment?
Is it Heidi?
Heidi.
Heidi.
Yeah.
Heidi, it's Julie. I think basically we know the behavior that the hospitals exhibited before is going to continue and likely will exacerbate. We know that that's not going to be different. I think the ED was already identified as an area that was already holding ICU patients, and we knew that was a problem. We also, I would expect there are probably PACU nurses waiting to call in with a similar issue too, because we have found that the PACU has been, prior even to this law, as an area of abuse, in which they don't have adequate ICU staffing, so they're using the on-call system in the PACU to try to recover patients that would otherwise be appropriately dealt with. So we can expect that the normal abuse of the institutions, because, first of all, if they were going to staff properly, we wouldn't need a law in the first place. So we know that that's probably not what their proclivity is to staff properly, so we have to deal with it. This goes back to the earlier question or comment people had about, gee, why take the ICU law when other places from a triage standpoint are a lot worse off? Nobody could agree with you more than the folks that had to make the difficult decision, only one of which out of the entire board is an ICU nurse, so they know it, they live it. Problem was, as we were faced with the circumstance going forward on the question for November 4th, just to reiterate for folks, if the question did not prevail on the 4th, we were going to be precluded from putting it forward for 6 years. So obviously our stance on that was this issue is incredibly important to the nurses everywhere. We cannot be on radio silence for 6 years on the issue. That's not going to be appropriate. So when we looked at the polling and all the information that we had, I think the general better strategy, even though more painful in the short term, was to pass a law that we could get limits in effect in the ICU, and then kicking the door open, argue the point to the rest that obviously you can't go to protect patients in an intensive care unit and then transfer them out and not have them protected elsewhere. So we felt like we were in a better position to actually get the limits for the other units. So it was more of a strategic question. Nobody would disagree with anybody out there who is under the assessment that the ICUs, in terms of a need, were the lesser needed area. Everybody fully appreciates that. Everybody knows that. So our goal here is to get them all the way through all the units, but trying to get that done was the question strategically. And I think a lot of people seem to not, even though the information was out there, were not fully aware that if it didn't prevail, and our assessment was it had a 50-50 chance in November, if it didn't prevail, you were going to be, the switch was turned off for 6 years. And that would pretty much prevent you, albeit at the contract negotiations and otherwise, the concern would be that your employer would be coming out and saying to you, well, it didn't prevail at the ballot, and therefore it's a non-issue. So it's just too important an issue to not try to get it done any way that we can. And if it meant having to take the first step incrementally, that was a safer bet for everybody, even though everybody felt that they were holding their nose to do it, to be perfectly honest. So we're going to have to fight like heck, as obviously. Dawn is mentioning the hearing on the 29th, and we'll talk more about it. We're going to want more input from people. But what we're trying to come up with is there's going to be regulations formulated on an acuity tool, all right? And we know that unless this thing is objectively done from the input of staff nurses in a way that's very clear, that's user-friendly, then it too will be abused like other aspects of staffing. So however good that acuity tool is going to make a difference not only for the ICUs but for everybody, and then will hopefully help us in the step forward for the other units as well. So anybody who's out there on the call, who's an ICU nurse in particular or others, will have the capacity to be present on October 29th before the Health Policy Commission. We would strongly encourage you to go to that. It's 11:30. I think we'll give out the location is at the end. The location or?
It's 11:30 to 1. It's Wednesday, October 29th, daily conference room, 5th floor, the China Trade Building, and that's at 2 Boylston Street, Boston, Mass. And all this information is on the website that you can look it up.
And just one last point I'd like to bring out to people is, there's one other state that has limits in the country, and that's California. And it's not lost on this when we revisited how long it took them to get it and how they got it, is the reality was they were able to get it through regulations in their ICUs first. And then after that, they were able to successfully argue to get it to the other units. So I think probably this strategy is probably one that's proven to work in other states, and hopefully we're going to make it work here in Massachusetts as well.
Thanks, Julie. Jackie, you're on the line.
Hi, I'm Jackie, and I work at Tufts Medical Center in an ICU setting. I had a question on when the estimated time the acuity tool would be ready to take off. And also, is the acuity tool going to be varying between certain ICUs, like adult ICUs versus neonatal ICUs and pediatric ICUs? Because I work in a neonatal ICU, and we have triples all the time. So I'm just wondering how it's supposed to all work out in that respect.
Thanks, Jackie. I'm going to ask Dorothy.
At the first, though, what was the first part of the question?
About the development of the acuity tool, and would they be the same for all?
Time frame, are they going to be different?
The time frame on the acuity tool is sort of a moving target. Our best estimate that we're hearing from them is somewhere between January and March. All right. That's what we're hearing from the Health Policy Commission, and the first hearing is October 29th. And Dorothy can answer more specifically the others, but the short answer on that is yes, they're specific to different types of ICUs, and Dorothy can provide more information.
Hi. We have been surveying the nurses of the Mass Nurse Association for about a month now, getting their ideas of what would be important in an acuity tool. We have designed 3 acuity tools right now. I'm certain that we have much more to do on this, but the way the tools are fashioned are the critical care is MICU, SICU, CCU, burn, and trauma for the adult acuity tool. It's all based on a 1-to-1 ratio. The second one is the NICU one, and the third one is the PICU one. We have gotten a lot of assistance from about 65 to 75 of your colleagues to help us fashion the tool. We just revised it again this afternoon, and the tools all have a very common denominator, and the common denominator is we looked at the environmental factors that are inherent in every single ICU, and I can give you a few of those. One is the competency of the nurse. The second one is the geography of the unit. Where is the patient visible, et cetera. The third one is the equipment that you have to use, and is it functional? The fourth one is the type of electronic documentation you use, and is it one full system or is it multiple systems? The next one is the medications, and are they available or readily available on the unit? The next one, so we put a lot of these into effect, are the support staff on the unit. Do you have physician? Do you have a secretary? Do you have ancillary personnel? Do you have an IV team? And another one is who's responsible for the duties off the ICU unit, because we have nurses in ICUs now being asked to start IVs on floors or assist with other procedures, or leave the ICU and go to pick up patients from another hospital. And the last one is, what kind of family supports do you have? So those criteria are in all the acuity tools that we put together, and then we have specific acuity systems that are just a one-to-one. It's based on a one-to-one ratio.
So the environmental stuff is same for all of them, but each then is separated out specifically for objective clinical criteria. So there are objective clinical criteria that are very specific to a NICU environment, and versus a SICU or MICU or PICU or any other ICU.
And we welcome any suggestions you have. I mean, we just redid it again today, and we had like 45 forms turned in, and we went through each one to see if we had covered everything that they suggested.
They're being categorized as well, and the clinical objective criteria is being generally categorized within systems. So you look at respiratory system, neurological
cardiac,
system,
surgical.
But varied, as you can imagine, towards the type of ICU that you're in, which might be slightly different on what the issue is that's affecting that patient population.
And just so you know, if you were interested still in filling out a survey, if you're an ICU nurse, on our webpage, massnurses.org, at the top story on there is a link to the survey tool. You can click on that, and it goes to a SurveyMonkey function, and you can fill out the survey for us, and we'll collect that data and put input into our process of coming up with our recommended acuity system for criteria for each unit.
Okay. Thank you very much. Roberta, you're live on the call. I'm sorry. Julie. Julie, you're live on the call.
Hi. In respect to like geological location, I was sort of under the impression that if a patient was in the PACU or the ER, if they were an ICU patient, they still would meet that criteria because they were ICU patients. Is that wrong?
That's certainly an argument we're going to be making, but the way they define this law, the hospitals are taking the position that the geography specific of the ICU is the place where the law takes effect. Our hope is that when we come up with the acuity tool, we'll be able to show, look, if you meet any of these criteria, waiting for a bed shouldn't be you're waiting for care. But that's going to be an argument with the Health Policy Commission who's coming up with the regulations.
Thank you, Julie. Joan, you're live on the call. I'm sorry, Roberta?
Hi, this is Roberta. I work for Steward Norwood, and thank you for hosting this town meeting, and thank you for your recap of the explanation of why the law went forward the way that it did. Although I was certainly in favor of my colleagues on the floor, I certainly understand the political implications, and I think that it was the right move in retrospect. My question comes in the form of the following. When I'm the charge nurse in the ICU, and with or without an acuity tool, I can identify what I need for staffing, and yet I do not have that. What is the law, if you will? How does it protect me? How do I go about getting what I need? In other words, what is the capacity of the law to do that to me?
The recommendation that we've made for the acuity tool is a 1-to-1 ratio. And this is what we're going to be submitted to the Health Policy Commission in the hopes that everyone is going to agree with us. We are also contacting firms that just do acuity tools, and to get the information that they have that would help us with the acuity tools, but it is based on a 1-to-1 ratio.
So I think your question was a little bit different than that. Your question was, basically, what do I do to make sure I get it once I know what I need, right?
So, I know what I need. What do I do to get it? Because let me give you an example. When I say to the current administration right now, are you aware of the new law that was passed? The answer is this sort of a deer-in-the-headlight look, and the answer I received last week was, well, we've got the lawyers working on it, and honestly, there's more to it than that. So my point is, as was mentioned earlier in this open forum here, we have people that are not, don't have a propensity to give us what we need or to uphold the law. So what do we do? If, in fact, this is now law, and I am supposed to have a 1-to-1 ratio, when, in my opinion, that's what I need, with or without a tool, how do I get it?
Let me go backwards from the question, all right, because we are in an area right now where they're running for cover and saying, as I'm sure you all have heard, the hospitals are basically saying at this point, because the acuity tool is not yet developed, that we then don't have to follow the law, or better yet, that the law isn't in effect until the acuity tool is in effect. I just want to be clear with people that we did talk to the Health Policy Commission, and indeed the law is in effect. So we have two problems, all right? The first one's easier to solve. One is we have patients that when nurses are going to either to lunch or if they're transporting a patient and they're doubled or et cetera, where somehow magically during your uninterrupted lunch break or your transport of a patient, they're magically assessed 1-to-1 or 1-to-2 patients have now become a double or, God forbid, a 1-to-3 or even 4 patients for a nurse watching during lunch. So that one is the first one and the easier one that we've been blasting away at. In that case, we have been making it clear that there is no room for the Hospital Association to hide on this one. There is absolutely nothing to do with the acuity tool. There's no room for error. There's no room for discussion. There's nothing. You absolutely, if a patient is assessed in the morning as 1-to-1, when you head for lunch, they're not suddenly 1-to-2. When you head for MRI with another patient, suddenly we don't change all the assessments. That issue, you should be screaming at the top of your lungs. And also, we have had instances where hospitals have said, well, there's a border. That patient's being discharged. So therefore, they're not an ICU patient, so you can take that third patient even. And that's clearly absolutely nothing in this law that allows that to happen regardless of the acuity tool. So those two we have been beating away in hospitals, and we've had at least 3 different hospitals so far in which nurses have actually pushed back heavily on this. And when I say push back heavily, you probably know what that feels like, which is you basically get on the phone to the supervisor, God, and everyone in country that you can talk to and say, it's not going to happen on my watch. Find a body, or I'm not taking this patient. I'll do whatever I have to. When they've pushed that hard, including a visit to the CEO's office by one nurse, they changed it. They did give them the staff. So where we're going to have a problem in the interim is we believe that even though the acuity tool isn't done, the nurse's assessment therefore reigns. Right? And until the acuity tool is done, unless there's an argument, some bizarre argument between you, the nurse's assessment should reign on what the acuity is of the patient, That's going to be a hard push for us right now until we have this acuity tool done. That doesn't mean to say for the nurses, you know the patients better than anybody. You're going to have to stomp your feet and scream at the top of your lungs to get this thing done, all right? Until the acuity tool is in place, and then I think we're going to be on more solid ground because of objective criteria that you really can't run away from. And even when this is all said and done, the answer is most of you know who are on the phone call. It's like anything in your contracts. Having something in writing doesn't mean anything until you're willing to do whatever it takes to enforce it, right? And that means you have got to do what you're doing, which is, and I know it's hard right now because we don't have the acuity tool, so you don't have a nice solid ground to stand on to be able to say, it's our assessment and the acuity tool shows that we're right, this is the way it has to be. On the other stuff, on the transport and whatever, that one's very clear, and when we push back, they've capitulated. And even including whether or not, first they're out of gate saying the law's not in effect, they have capitulated on that as well. So there are many hospitals out there that told the legislators that they were fully ready and able to do this, that they were already doing it. And as you all know, as much as we find the ICUs are the least of the worst, the bottom line is they're still bad, and there's still problems. And so we're trying to get it fixed in there first with staffing, and then if we can be successful in that, I think we use that as our tool, if you will, to move forward to the ICUs. So it's the long-winded answer to you're going to have to scream loud, use every vehicle at your exposure inside your bargaining unit, including through whatever your committee has sent up to fight, but you cannot let it go. Nobody in here listening to this, if you've assessed your patient and you know they should be a one-to-one, you should not let that go, all right? And get on the phone with your manager, with your supervisor. Take it right up the chain of command and ask for the CEO's numbers if you have to. And say flat out to them, you understand it is my clear assessment as a registered nurse at the bedside that it is in this patient's best interest to be a one-to-one. And if you do anything other than that, it is clear to me that you are intentionally violating the law. And I want people to take it right out, because whatever we do now, folks, is going to make the difference. If we let them by easy and don't batter away, they're going to take a mile from us. So push back as hard as you can. And for those of you who aren't in the ICU listening to this, the ICU nurses, like it or not, they're the first in the front line of this battle right now. Whatever they can do and whatever we can support them to do to be successful in this is going to clear the path for the rest of us.
Thank you, Julie. I'm now going to go to Evelyn. Evelyn, you're live on the phone.
I work at Tufts Medical Center in the CCU, and we constantly are in a battle for staffing and are constantly being challenged and having major discussions all the time about what our staffing, they feel the managers, our staffing should be, and against what we feel our staffing should be. What I'm hoping and I'm asking, is this acuity tool going to be something that we can fill out and say, look, here's my assessment, end of conversation. I want to get back to taking care of my patient.
Absolutely. I think that goes right along with what Julie just said. It's one thing to have a law. It's another thing to be enforcing that. And you will have the tool in front of you, and that's what you need. And we hope to get that to you as quickly as we can so that you can utilize that tool.
First and foremost, we have to fight for the tool that we want, all right? Exactly. We're going to come in for what we want. You can bet the hospitals are going to come in for what they want, and you know what that's going to look like, the status quo or worse. So I want people to fight for this and come with us to this hearing and to give us as much input as they can. We're asking, by surveying the nurses, for the tool that your patients deserve. So that means this is the here and now for you to give us that answer. I'm going to give you a couple examples. You were in a CCU, is that right?
CCU, yep.
So I'm just going to give you a couple of, this is by no way exhaustive. There's a lot of different examples on here, but and any one of these, like cardiac, it would say septic shock requiring continuous monitoring and multiple intravenous vasopressors and with hemodynamic instability. Hemodynamic instability requiring frequent infusion, medication, titration, monitoring. Something under a surgical would include like unstable op-day major surgical patients such as AAA, open day, open heart surgery patients during the first 12 hours. I'm just kind of highlighting some stuff that people put in. Neurological, active suicide patients who are medically unstable and or violent, drug overdose with major systems decompensation, active substance abuse withdrawal with hemodynamic and neurological impairment, medically induced coma, subarachnoid hemorrhages. I mean, there's a litany of very specific clinical issues that come up in all of these different ICUs that the nurses have been giving us to say, you know, if you check the box on any one of these, and I mean any one of them, it is hands down that is a one-to-one patient. And it's when none of these boxes are checked is when the nurse's assessment will then indicate whether or not a patient could be doubled. And that's what we're trying to come up with is you basically check this off and it's done. And until those boxes are no longer checked off, this issue should be not discussable, right? So again, that's not all of them. That's just kind of try to give you a sense of a sample of some of the things that are being put off that you would check off.
Thanks, Julie. We're going to go now to Brian. Brian, you're live on the phone? No, Brian. Brian?
Yes. Hello?
Yes.
Hello.
Thank you, Brian. Your question?
First, I'd like to say thank you for hosting this informational town hall. I think it's a great event. And my question is, I work in the NICU at UMass Medical Center in Worcester, and our CNO, Diane Thompson, said that she will not recognize the law until the acuity tool rolls out in March. She stated this at Labor Management. Questions that I have with this is she in violation of the law at this time? And
Absolutely she is, Brian.
HPC says the law went into effect September 28th. They say they count their 90 days to be the effective. We had counted it as October 1st, and we went with the longer date. But HPC says they counted 90 days, because if you don't know, when a law is passed, unless it specifically says otherwise, the law goes into effect 90 days from its passage. And so that would be from HPC standard, September 28th, they say the law went into effect. So, Brian, anybody, your folks, you should be there, have somebody there on the 29th. It would be very important for you to be able to say to the Health Policy Commission Executive Director, I want you to hear exactly what the Director of Nursing has said to the nurses in the NICU at UMass.
I'm currently scheduled for Hello?
Yes, Brian? I'm sorry, you broke up for a minute.
Yes. The second part of this is, how will the law be implemented without the acuity tool at this time?
The clinical judgment of the nurse. The law is in place right now that it is one patient to one nurse, and that is the law. The acuity tool is being worked on, and
you can do doubles, but the doubles are based on the assessment of the nurses. And the way the law is written, too, just so the nurses understand the way you sort of should frame of reference you should take from this, is that it's not just the individual nurse, it's the group. So when you come into a unit and you all collectively look at the patients in the assignment, right, you don't go, oh, I got there early and so I'm taking this, whatever happens, happens, right? I mean, you have a discussion amongst yourselves, and there are often circumstances where there may be an assignment filled out in advance, but then it's altered based on the assessment of the nurses coming in. There may be patients traveling or other issues that have come up, or maybe you followed a patient consistently for a couple of days, and for continuity, you want to continue to follow. There's lots of reasons why that assignment is shuffled, as you all know. But it's a group effort, and it's a group assessment. So you should look at this law very much like that. If you as a group in an intensive care unit have made the assessment of who in that unit is a one-to-one and who in that unit is doubles, and have figured out how then their staffing needs need to be, you should be addressing it as a group as well. It's not, what I don't want to encourage happen is for a person to say, well, I got my one-to-one, and oh well, I guess you can fight that out with the supervisor. The group really needs to stand firm that it's their collective assessment of the needs of the patient, so that when you're addressing the director of nursing, they're not addressing just one of you, but they're addressing all of you.
Thanks, Julie. We'll go to Michelle now. Michelle, you're live on the call.
Kim.
My name's Kim.
It's rolling.
My name's Kim. I work at Brigham and Women's in the ICU setting.
Okay.
My question is, what are the repercussions to the hospital administration when they're in violation to the law? And how does one go about making sure that something is done?
Right, at this point, we don't have any regulations from HPC on where we go with the complaint, so that's one of the issues that we want to address with them. But I would say, to the extent that they're violating it in advance, I would want people to call the Health Policy Commission. And there are instances that you need to go through your committee, because we are discussing with individual bargaining units particular actions at facilities. So, you know, we won't sort of say a generic thing over the phone other than I want to make sure that HPC knows. But you've got to go through your committee at the bargaining unit level, because, as I say, there are some cases that we're looking at whether or not we want to go to court on certain instances, or there are others where we've been taking particular action. There are others where we're going to press on it. So the strategies vary, so they're specific to your unit, and you should talk about it with the committee.
Kim, also, that you're at the Brigham next week, next Wednesday, there's going to be a press conference outside the Brigham at 12 noon, because the Brigham management has said they are not going to follow the law, and they're doubling which are transplants and people, as you probably know, who absolutely should be singled. So we are going to hold a press conference tactically, on purpose, the week before this October 29th hearing, to raise the issue that Brigham and Women's is blatantly violating the law, endangering their patients, providing less care than they used to, and to help shine the light on them and embarrass them as we go into this hearing on the 29th. So I hope if you can't be there, many of your colleagues can be out in front of the hospital, in front of the Shapiro building next Wednesday.
Can I ask a question, too? This is an opportunity for us, too, as we're kind of addressed. Oh, she's not on the line anymore? Oh, all right, she can't hear me anymore. Maybe others can address this. One of the things that's going to come up at the Health Policy Commission is they're going to ask about also reporting. And while we look at the regulations, we're thinking in terms of what are the types of things that we could ask on reporting that would hold the, fire to the feet of the institutions. Like whether or not, if a nurse disagrees, do they have to inform the patient directly that the hospital is attempting to override the nurse's assessment? Do we ask for certain posting things? So we're definitely looking for some creative ways, too, that might be helpful to you, for us to specifically ask HPC that you think, ooh, if we had this, if they did this, that would, help us make sure that they follow this law. So anything you've got out there on that, we'd love to hear it.
And again, any of that feedback, you could get that to us right at massnurses.org. Go right on the website or call M&A directly, and we'll be glad to take that information from you. So I'd now like to go to Michelle. Michelle, you're live on the phone.
Hi, how are you? Thank you very much for this meeting. I work in the step-down unit at St. Elizabeth Hospital, and my concern is that the law went into effect knowing the ICU that I know. We also have a lot of problems as it is now in the step-down unit where we're overstaffed. Patient to nurse ratio can be anywhere from 3-to-1 to 4-to-1. We are seeing a lot of the patients that are coming from the unit now actually are patients that supposed to be in the unit, and they are now on the step down with a 3-to-1 and a 4-to-1 assignment. We're having a lot of patients that are having emergencies where we have to send them back to the unit where we don't have any room in the unit for them, so therefore they stay on the floor. The nurse is still asked to take care of this patient on a 3-to-1, 4-to-1 ratio and still have to work the same as the ICU nurse. At this point, I'm saying if the ICU nurses do have some ratio, there must be something that puts into effect when these patients leave from the unit and they go to a step-down unit because the ICU is overflown, and that we now are responsible for these patients that acuity-wise should be in the unit, because I listened to your example of the cardiac requirements, and unfortunately, I take care of those type of patients. Unfortunately, with two others, sometimes I'm the one charge nurse in charge of a whole floor and still taking care of these type of patients. And it's really bad. It's I'm worried that the unit is going to have the 1-to-1, but then when they come outside, we are still taking care of high acuity patients that should be in the unit on the floor as a 3-to-1, 1-to-1. What safeguards are we putting into place that these patients are also protected in some way? Because are we now considering what is considered a step-down unit? Are they allowed to overflow the step-down units in that manner? And how can we protect these patients even though it's not, I understand that, it's a step-down, but there are general floors also. So I think the step-down unit have to be kind of protected, because like the PACU and the ER, we are asked to take these overflows.
So
what are we doing for that?
Well, Michelle, as one of the things that will help you, I believe, going forward is the development of that acuity tool that will be very clear in identifying those patients that should be in the ICU setting with a 1-to-1 ratio, not a 2-to-1, not a 3-to-1, not a 4-to-1, but to identify those patients that require that 1-to-1 care going forward. And again, one of the most important things about getting this acuity tool right and getting this law fully up and running is the impact that it's going to have on the other units going forward. And that is the goal, is to get the safe limits in all of the units in all of the units and all of the hospitals. So the importance of this acuity tool can't be stressed enough, because that acuity tool will help you in identifying those patients that don't belong in the step-down but truly do belong back in the ICU.
We will certainly be making the argument. If we're successful on the acuity tool with pushing for what we want, we're going to be making the argument that if a patient's assessed an ICU level of care, then they need to receive the ICU level of care in terms of staffing. So we'll be pushing that. I think, like Donna says, if we have an objective tool that we can say, well, how come you approve this for in the ICU, but the patient meets this criteria and they're not in the ICU, they get a different standard of care, I think it'll be a pretty effective argument for us to make that they're basically, as we all know, dumping patients.
Thank you, Julie. I'd like to go to Jean. Jean, you're live on the phone.
Yes, hello, my name is Jean, and I work at Tufts Medical Center in the surgical trauma ICU. And we, too, are facing challenges with taking care of 2 patients at a time. We used to staff our unit with 7 nurses for 10 patients. That went down to 6, and now it's gone down to 5. And so even if we were to stipulate and the hospital were to agree that, okay, everyone can be one-to-one, there are no nurses to take care of these patients, because as nurses have left through natural processes of attrition, those positions were taken out of the budget. And now we don't have positions, so we don't have nurses. So everybody's doubled up in our ICU. We double patients out of the operating room. We double trauma resuscitation patients. We double patients who are traveling off the unit to procedure areas where the nurse is gone with the patient for upwards of 2 hours, and somebody else is looking after their second patient. So even if the hospital would say, okay, fine, we agree that these patients are one-to-one, where are we going to miraculously find all these nurses without mandating overtime until the hospitals post and hire into positions? That's a really big challenge for us.
Right. Well, I think first thing is this isn't breaking news as of an hour ago. They've known about this law for the past 75 days or so, and they had time to get other nurses into place. It's their responsibility to staff accordingly, and the fact that they have actually done just the opposite and reduced the number of nurses available to take care of those patients, that's something that I want the Health Policy Commission to hear from us on the 29th, that despite having this in place, that we have tertiary care facilities in downtown Boston that are continuing to cut staff and do exactly what they're doing to you. And David?
Actually, this is David Schulmeyer. That's exactly what happened at the Brigham and why we're holding the press conference. In August, after the law was passed, they cut 5 beds from their trauma ICUs, and they cut 3 beds from their thoracic ICUs that do the lung transplants, and laid off 15 nurses. And that's the kind of thing we're going to have to alert the public, and hopefully through the reporting process with HPC, one of the things we've asked for is that that the nurse be allowed to tell the patient when the hospital has violated their assessment, so that if management tries to violate your assessment of a 1-to-1, 1-to-2, you get to tell the patient's family that they are violating the law. That's one of the things I don't know if we'll get it, but it's the kind of public pressure we're going to try to use through the reporting process to force them to do the right thing. And in doing that, then they have to hire nurses if they're going to avoid losing face and violating the law.
The short answer to your question, though, is they're going to have to post and hire jobs.
Yep.
You have 2 choices. You either don't accept the patients or you hire nurses to take care of them. And and we're going to have to use pressure tactics, which is always the case in anything that we do. We have to use pressure tactics in order to get it enforced. But I just want people also on the call to remember that the Massachusetts Hospital Association agreed to this language. Senator Rosenberg, when he put this forward, gave it to the Massachusetts Hospital Association and said, I'm going to pass this. Are you agreeable to it? Right? I'm sure they didn't like it, this piece of it, but they agreed to it. So they knew in advance, as Donna says, exactly what this is going to entail. So we're just going to have to push hard with HPC, and we're going to have to put as much pressure as we can to force them into the position of hiring. And if it takes public embarrassment to do it, then so be it.
And in the meantime, there's agency. They can fill in with agency until they get people up and running. But so there's no excuse not to do it. If you need the numbers, they can do that while they're training others to come up to par. So it's crap when they say they don't have anybody, to be honest with you.
I'll make an obvious statement that nurses on this phone call know. If the CEO's husband or wife is in your ICU, would they find the staff? And I know the answer is a rhetorical question. The answer is yes, okay? So I think anybody off the street that we care for is entitled to know less.
Yep.
Thank you, Julie. I'd like to go to Sharon. Sharon, you're live on the phone.
Good afternoon. Thank you. I am an ICU nurse at a Steward facility in southeast Massachusetts, and we have a new wrinkle in our ICU to suddenly get around this. That is that we have boarders. Sometimes we have floor overflow boarders. A lot of time we have tele overflow boarders. And so then they'll say, well, one of you IC nurses, you can take care of those 5 tele overflow patients. Even if there were 3 vented patients and a surgical patient or whatever the other mix is. And they say that they don't have to do anything because that was what our contract said, and there's no acuity tool for them to have to listen to having all these strangers in the ICU. And then if there's a rapid response or a code call, heaven forbid, there's no place or no other nurse to put with this person that's now coming. I hear my sister nurses saying about sending 2 new patients out to the floor, but I don't know what to do when I'm in the ICU and now I have a 5th who is an ICU patient. Thank you.
The answer on the border patients, because that actually came up in the discussion of the law, and it was quite clear that if they put a patient in the ICU, then they're going to treat them like an ICU patient, and we weren't writing a law for the exception versus the rule. So MHA ceded the fact that if they have a patient in the ICU, it doesn't matter. It's the most that assignment can be is 1 to 2, period. It's their job to move the patients out accordingly, not to board them in the ICU then. And they absolutely were well aware of that. That is the one issue I will say. When we have pushed back really hard in some of the institutions, it's obvious to me that they are aware of it. And in talking to the CEO of the Health Policy Commission, they are aware of it because they have backed off of that issue. At 3 different hospitals where that has come up, the hospitals have backed off. So they know they're wrong on that issue. So the short answer is if it's a border patient, it can't be more than 1 to 2 as long as they're sitting in the ICU. And they agreed to it. They understand that we're not going to make ICU limits based on the exception rather than the rule.
Can I ask on that idea, how does that apply when you have a mixed unit ICU, PCU?
On a mixed unit, just so you know, you could have a unit that's shared, but they're going to have to be completely separated in terms of the assignment. A nurse cannot have a shared assignment that goes over 1 to 2. Because CMS, the way they reimburse, if you mix that assignment, CMS, Medicare will not reimburse for the ICU assignment. So if there's nothing else that matters to the hospitals, it's certainly money. So you can make it clear to them that they won't get their reimbursement from CMS for the ICU patients if they attempt to mix those assignments.
In addition to the mixing of those sorts of patients, our facility is training the ICU nurses to recover patients as if it were a PACU. So they'll have a PACU nurse and then an ICU nurse that is a backup but also has her own assignment. So in situations where this patient is a 1-to-1, she has her patient, but if something goes wrong with the PACU patient, you know, how does that work? Because it seems like it's a recipe for disaster.
I can only say that once the patient's in the ICU, they're an ICU patient. Right. That's the way the law has determined it. If they want to house patients in the ICU, they've agreed under the law to treat them as ICU patients now.
Thank you. I'd like to go to Ellen. Ellen, you're live on the call.
Hi, how do you do? My name's Ellen. I'm a nurse in the emergency room in St. Elizabeth's. I just wanted to say, even though this will impact my practice tremendously over the next few years, I recognize that the law is a good stepping stone. I'm glad that it's been passed, and I hope that it's used appropriately and that we can then roll this out to patients everywhere. I suspect that we'll see an increase in mandatory overtime, and I'm wondering, is there any mechanism to address that? Is there going to be any public reporting on that? I just wanted to say, also, when the campaign was in force, the buttons that we wore that said, "Ask me how many patients I'm taking care of," were very effective. I had a lot of conversations with patients and families around that, about those buttons, and I think that it was that was a good tool. The other thing I'd like to say is, what will happen to the rapid response team? I know in the hospital where I work, typically it's a nurse in the unit who already has a one or sometimes even a two-patient assignment who's then the rapid response nurse. Has this been taken into consideration? Thank you very much. Thanks for taking my call.
Thank you. Julie?
Going backwards, the rapid response, yes, and one of the environmental factors, Ellen, that were on there, that's one of the issues that's been addressed, is that if the ICU nurses are responsible for any other responsibilities outside of the ICU, that is considered an environmental factor that has to be taken into effect. The reason for that is, obviously, even if we could double patients, then we can't double patients if we have duties beyond that which exists in the ICU. So there's that. Also, with that included a bunch of other things that Dorothy mentioned, and also admission discharges were also included in the environmental. So that would fall into that category. And then I'm trying to think of what the beginning was.
The mandatory overtime.
Oh, the mandatory overtime issue, interestingly enough, Health Policy Commission is the group that created the mandatory overtime law, which is one of the reasons why we wanted to use them, is nobody had a lot of confidence in the Department of Public Health. But the Health Policy Commission had done the mandatory overtime law, and while we would certainly even make it stronger than it is, it actually did come out to be one of the best laws in the country. So if they attempt to end run the ICU by abusing the mandatory overtime, we're actually with the same agency, which I don't think is going to take kindly to that at all, because mandatory overtime, as you all know, is really very limited, extremely limited circumstances of use, and compliance with a law that's in pre-existence would not be one of the criteria for its usage. That's not an emergency.
Exactly. They're very clear, and what determines an emergent situation is not anything to do with staffing. So they can't use, we have to staff one-to-one as an excuse to use. It's absolutely verboten, so it's against the law. They can't use it as an excuse, and we can push back on that very effectively.
Thank you, David. I'd like to go to Dan. Dan, you're live on the call. Dan?
Dan's no longer anymore.
Joanne? Dan, are you still there? Sheila? Sheila, you're on the call.
Oh, hello. It's Sheila, and I work at Boston Medical Center in one of the step-down units. My question originally was about what can we do for these overflow patients that are sitting in the ED that should be in the ICUs. It sounds like you guys aren't surprised that the hospitals are doing that and kind of leaving ICU patients in the ED and leaving ICU patients in the PACUs. We're lucky. In my experience, in my own limited experience, I have not seen us having patients pushed out to us too early. But I have anecdotally heard the ER is having an incredible time of boarding patients that should be in the ICU. So my question was answered that that the law is just for the ICU, but my concern is that these nurses in these units that are having to take the overflow, I hope they understand that they could do unsafe staffing. Has that been more punitive? Have you heard that? Is that something that they should be doing, unsafe staffing, when they're having all these overflows and we don't have the acuity tool yet?
Everybody should understand that just because we're managed to kick the door open on a law for the ICUs doesn't mean that that's a pass for them to do unsafe staffing everywhere else, regardless of the law's existence, right? I mean, we still need to fight for those things. So, yeah, we should be filling out unsafe staffing forms in the other units. We should be continuing to do persuasion. And as you can imagine, we're hoping that the argument now gets stronger for the ED nurses and the others, because you're able to say, hey, look it, This patient's been identified to be transferred to the ICU as soon as the bed is available. But look at how we're staffing now. And you can imagine when it comes to public and talking to the press and talking to the politicians, it's going to be awfully hard for the hospital to wiggle out from underneath that. Oh, okay, 20 minutes from now I'm at this standard, but now I can be, 1 to 4 in an ED? So, yeah, we definitely, people need to fill out the unsafe staffing form, and they can't be quiet. Nobody can go quietly on this stuff.
And work through your local bargaining unit committees and your leadership to bring this to the labor management. This should be an ongoing process, how they roll out this and the impact on the rest of the institution. So it's part of an ongoing strategy of trying to manage the staffing throughout the hospital as we try to push for the next law.
This is Linda, ICU Norwood. And the other thing, I talked to one of my colleagues last week. I was out for the week, and she filled out 3 unsafe staffing forms in 1 12-hour shift in the ICU because they were unable to accommodate the one-to-one nursing. So I would encourage people, even in the unit, to do it. But you got wherever you work, if you're in that situation, absolutely. I was really excited to hear her when she said that. Yeah. Good for her.
Good for her, right?
Thank you, Linda. I'd like to go to Betsy. Amanda, you're on the call. Amanda?
Hi, yes, thank you. I work at UMass University campus, and I work in the acute care pool where we have been sent to the ICU and told, oh, they're just boarders, oh, this patient's pretty much stable, you guys have to go and take care of these patients. When we brought up, I am an acute care nurse, I am not an ICU nurse, it got pushed to the issue so far that Diane Thompson told us a nurse is a nurse is a nurse, and you are going to take care of those ICU patients, or there'll be insubordination. So when Diane Thompson, our CNO, is telling us we will be insubordinate for not going to an area we are not trained to go to, and now these areas are not going to have the staff do one-to-one nurse-patient ratios, what's to say she's not going to keep sending us there without proper training and telling us we will be insubordinate if we don't go?
Well, first of all, I would definitely fill out an unsafe staffing report, and second of all, I would talk to your associate director, and I would consider filing a complaint against her with the Board of Registration in Nursing. The board is there to protect the public, and if she's enforcing unsafe care in her area, I think she should be reported to the Board of Registration. And you don't have to do that by yourself.
We had a no confidence vote in her, which I don't understand. Apparently did nothing because she still does these things. She brought a patient up herself from the ER that was actively stroking to an OBS unit and left them there. She doesn't care.
Put it to the board.
Yes.
Then you need to report it to the board because the board will not stand for that. And, the no confidence vote, that's like,
It's good for the press. It's a good way to handle it. But if you're not getting results,
right.
move on.
I would definitely call the board because she's impacting patient safety, your license, and livelihood. And, the board needs to hear that. And, she may change her tune when she has to sit in front of the tribunal and answer their questions. So I would definitely call the Board of Nursing and file a complaint.
Thanks, Kathy. I'd like to go now to Betsy. Betsy, you're on the call.
Hi, I work at UMass in the neurotrauma burn ICU, and a lot of my questions have already been answered. But I guess my concern is that we had a contract where we increased our staffing ratio, and that has not been honored at all. Maybe every once in a while we'll have a resource nurse without an assignment. And when she does not have an assignment, he or she doesn't have an assignment, they'll have to do tasks for the manager, they'll have to do people's blood sugars, but they're not really focused on the resource duties. And I think now at this point people have filled out so many unsafe staffing, so many STARS reports, and it's gone nowhere. And then, as you just heard, we have the wonderful CNO that has been a tyrant. And I'm concerned that when we transition to this new law, we get the acuity tool, we're not going to have any change from our administration at all. And how are we going to get the backing? I mean, we can't get it now. We haven't gotten anywhere, and I'm just really concerned that law or no law, they're not going to honor anything. They want to keep it status quo. And we right now have doubles that should not be doubled. We have violent patients that, they're injuring nurses. They're falling out of bed. We've had suicidal people with no one-to-ones, and they expect the nurse to be the one-to-one. I've never seen it like this, and I don't know how this law is going to make it better because the hospital's not going to honor it. That's my concern.
Hey, Betsy, it's Julie.
Hi, Julie.
I recognize some of these voices. It's like, you guys are in a hellhole out there, and I know it throughout the UMass system they add to. I mean, places are bad, and UMass is definitely going bad everywhere there. So I know that your committee is working with a group to try to come up with various strategies throughout the system, so I don't want to undermine that work. But I will say this much. We have it very much on our minds as this law goes through that we might have to take certain places and go to court. And I don't know if UMass is going to be one of them, but when you say, well, how do we enforce it? We're not going to have spent the better part of a decade, and I personally have not going to have spent the better part of a decade to find out that a law is not enforceable. So we'll use the persuasion that we do in the bargain units, but if we have to take particular test cases to court to get it enforced, then that's what we'll do. And if they're not violating it, I think that's going to speak to the issue, too, about then whether or not we go after punitive penalties through HBC or other legislative means if we have to. But courts and
Well, I personally hope that that's an option. I really do, because I can't see them changing unless there's punitive repercussions.
Yeah, I think maybe if their reimbursement or their licensure is at risk, then maybe they'll pay attention. But it might be. I don't know for sure. I know your committee's working on stuff, but when we come down for this acuity tool finished, if there's clear violations, we're going to have to probably pick one or more places and fight it out in court if they don't follow it.
All right, so I'll keep my hopes up.
Yeah. In the meantime, feel free to use any and all active persuasion methods that you guys decide in your creativity to do, because I know that you will.
We will. We'll try.
Thank you very much. I just want to remind people of the time we have time for just a few more questions, so I will next go to Joanne. Joanne, you're on the call.
Hello.
Hi, Joanne.
Hi. Thank you, everybody, for doing this. I really appreciate it. My name is Joanne, and I am a laid-off nurse from UMass Medical Center, forcefully, because, first of all, let me say I'm glad you started with the ICU changes, and I really like that the DPH is going to weigh in on the acuity. And I think that's going to help dumping ICU patients out onto the floor that stay there for 12 to 24 hours and turn around and have to go back. So I'm really glad for the bedside nurse ICU input there. What I'm concerned about, though, is looking down the chessboard and the 5 moves that my CNO is Machiavellian about. They are now going to go for magnet status there, and they want to change the mix from 7 and 4 PCAs to 8 nurses without resource taking an assignment and 1 PCA in each hall. And that is one of the reasons I'm laid off, because I can't do that kind of nursing, and it's not going to work. And we need help on the floors after you guys finish with the ICUs. We are desperately, desperately fighting a war that we're losing there.
Got it. And
thank you.
We're filing, just so everybody's clear, we're filing the legislation on the floors in the other places in January, and we're having active discussions about whether or not we go back to ballot for the rest of it, too. And we need to have a very full, robust discussion about that, because we can refile for 2016 for the rest of them if we're fully ready and prepared for that fight the next round. But yeah, we're refiling, and no, we get it. There's no way that this is going to work until it's like whack-a-mole, right? So if we get it done for the ICU, it pops up elsewhere. We have to get everything locked down in order for this to make a difference.
Thanks, Julie. We have one more call on the line. Lisa? Lisa, you're on the call? Lisa, you're on the call?
Can you hear me?
Yes, I can hear you, Lisa.
Hi, I'd like to tell you that my name is Lisa, and before I go on, I really want to thank you for making me part of this, and I'm just so appreciative of everything that I've been hearing. To broaden things a little bit, and I just want to tell you that I work in an outpatient rehab that is many times accepting patients from ICU, CCU, direct from medical ICU. I work on a floor where patients have been extubated and not able to, and they're not able to wean off vents. We do tele, et cetera, Our patient nurse 1 to 5, 1 to 6. We hang cardiac drips. We hang cardizem drips. Our assessments sometimes mandate us to have 15-minute checks to make sure that these vasopressors are in place. And my concern is that with the assessment tool in place, and the best thing that I can appreciate is that you wanted this, you did applaud the information, is that we're going to continue to see these type of patients in an outpatient rehab because I believe administration is going to be forced to uphold this law, not break the law, continue to make patients step down from ICU, and I just wanted to make a statement more than a question and just put it out there that my concern is that if we're not able to use that assessment tool in our settings and step-down units, how is that going to, help nurse-patient ratios and safe practice? So my concern is that the administrators, again, are going to wiggle around, excuse my expression there, and discharge patients too quickly, readily from ICU to prevent having to hire on more nurses. And how can we prevent that? And how is this law going to help that?
Actually, it's a good question, and on the rehab. First of all, you're scaring me to death on what you say. Everybody around the table here. There's got to be about 50 people in the room, and they're all completely freaked out at the type of patients that you're taking in outpatient rehab at this point. But beyond that, not to answer a question with a question, but it's interesting that you're raising this because I wonder for the ICU nurses, one of the reasons for this call is for us to also kind of vet and get more information. It would seem to me that maybe within the tool we need to do something as well for the capacity for the nurses to be able to hold on to the patient prior to them being ready for discharge. So it's not just about 1-to-1 and 1-to-2, but when it is that you're ready to leave the ICU setting is something that maybe we need to talk and address that with HPC too, because that goes a little bit at the question about people being held out of an ICU before they can get in, that maybe the vice versa is, what about patients being sent out before they're ready to go out? So maybe we can take a look at that and see if we can try to build a little bit around that in the acuity tool and also at least in our discussions before the Health Policy Commission so we can highlight it and find maybe whatever way we can to try to stick a fork in that from, happening.
Where do you work so I don't end up there?
Yeah. That's pretty
okay.
God help.
Any last thoughts, comments from anyone? Okay, I just want to apologize to anyone that wasn't able to get on the call tonight. Did you have something?
No, just a reminder to people, the hearing tomorrow at 10 o'clock on a bowl at the State House if they want to go. Remember that we were asked to testify, and they apparently don't want to hear. The words that we got were, we need to talk to people at a high level, which I think, without really getting into an explanation, the fact that somebody would say that we need to talk to people at a high level and not want to talk to people in the front line probably sums up the reason why we're in this cluster that we're in right now. Exactly. So if you can get there at 10 a.m., I encourage you to do so, and to get on your calendar the 29th. Any information, if you haven't filled out surveys, please fill them out. We'll be taking the information and updating and perfecting as much as we can right up until the last minute. Please make an effort to get there. Make sure that your hospital is represented at this hearing.
Where is it at the State House, David?
B2, room B2, which is in the basement at the State House at 10 a.m. And just, we will be doing more of these calls in the future as the campaign develops, as we go forward to to update you on where we go to get the limits in other units.
Kathy, did you have a comment before we close? Okay. So that wraps up our town meeting tonight. We hope this has helped your understanding of the issue and how we are moving forward. Again, we invite you to attend the Health Policy Commission listening session in Boston on October 29th. The information on that is also on the website. Finally, we would like to know if members found this telephone town meeting helpful, and if you would like to utilize this for the staffing campaign or other issues going forward. At this time, could you press 1 for yes and 2 for no? Thank you for your participation and for your work on behalf of our patients and our profession. Good night now.
Thanks, everybody.
Thanks, everybody.
Thank you.